Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Well, hello and welcome to Central Line. I'm your editor and host, Dr. Adam Stryker. Today I have Dr. Primm with me, and Dr. Primm is currently on the editorial board for SEE, or Summaries of Emerging Evidence. Today we're going to talk a little bit about a few of the studies featured in the 42B issue, all related to anesthesia for GI endoscopy. Dr. Primm, welcome back to the show.
Thank you, Adam. Great to be back with you and to speak with you more, and always excited to tell you more about what's happening with these studies from Summaries of Emerging Evidence.
Excellent. Well, you have been on the show before, and so I'm not going to necessarily have you introduce yourself again, but what I'd rather have you do is talk a little bit about your practice focus, non-operating room anesthesia, and GI, and how the studies we're about to discuss impact your clinical practice.
Yeah, I'm in charge of the endoscopy for anesthesia at NYU Langone, which encompasses many sites, many patients, and it is also part of the broader field of non-operating room anesthesia, or NORA. This might be, referred to as out of operating room anesthesia, out of OR, things like that. And the studies that I picked out and that we'll discuss a little bit more kind of shine a light on the future of NORA, and especially GI endoscopy, and in these in particular, going through new drugs that are coming down the pipeline to, the value that anesthesiologists will bring to the table with these, and really how our practice in relation to this field will change over the next 5 to 10 years.
Well, let's start with how we anesthetize patients. Tell us a little bit about the remimazolam study.
Yeah, so this is a paper from Anesthesia and Analgesia from last year, entitled "A Comparison of Remimazolam versus Propofol Blood Pressure Changes During Therapeutic ERCP," and it's a randomized controlled trial. A bit of a background: ERCP, it is the most common advanced endoscopic procedure that's done. And what we're doing is it's this upper endoscopy, the scope that is doing these therapeutic, typically, interventions on pathologies in the common bile duct, the pancreatic ducts, and the ampulla. We typically use a lot of propofol for this procedure, whether it's induction for general anesthesia or if it's for deep sedation. But these patients do have an increased risk of hypotension compared to other patients. And some of this is due to their just comorbidities, the procedural positioning. Patients tend to be older and sicker. And so remimazolam has been used in the surgical literature and been shown to decrease incidence of hypotension. And it being an ultra short acting benzodiazepine agonist, a lot of interest really has been shown in where else can we use this drug to benefit our patients. And so they hypothesized that this one could work in this patient population. So, like I mentioned, this was a single center RCT that was conducted a few years ago, and they randomized their patients to either receive remimazolam or propofol for induction. And their primary outcome was the change in mean arterial pressure from baseline during anesthesia induction, and also what they call the area under baseline map, which is the difference between the map and the baseline map multiplied by the number of minutes below baseline throughout the endoscopy. So basically a general indicator of how long a patient is hypotensive. And then they define that as a map of less than 65 for at least a minute. They also looked at some other factors, and if they need vasopressor, if they had any significant complications. Interesting in the study, I think, so that they could get really exact blood pressure measurements, they had A lines placed, and they also used a process EEG, I believe it was the BIS, to keep patients at a consistent depth of sedation to compare the two drugs. The doses that they used, which maybe not everyone knows common doses, the remimazolam group was 0.2 milligrams per kilogram compared to the 1.5 for the propofol. And then after that induction, they used a remifentanil infusion to get these patients the level of anesthetic that they wanted. Also, interestingly enough, they used an endoscopic laryngeal mask airway instead of an endotracheal tube. That in of itself is a choice, and then maybe not be my choice, but it is the way that they secured their airway for this procedure. And all patients received flumazenil that were in the remimazolam route, and the propofol group just had a equal volume of saline placebo, basically, control that was given. And when they got to the results of the study, they did see that remimazolam did have less hypertension. So they had about a mean difference of 17 millimeters of mercury between them, which is quite significant. And that area under the baseline map was lower in the remimazolam group compared with the propofol group. Many more patients had episodes of hypertension with propofol. And even so, they really didn't find any differences in the vasopressor administration between the groups, and there were no serious adverse events that were reported. So my big takeaway is that, this is a drug that's a good candidate. It's a good candidate to lower this incidence of hypotension on induction. And using it in these ERCP patients, I think was a smart way to build this study because hypertension is definitely a problem for these patients. They may be coming in with cholangitis, they may be septic, cardiac disease is common. These are long procedures. And, these are the patients I think about when I think about what's an alternative to this drug that's known to cause hypertension on induction.
And you think the one random clinical trial, you think it's enough that would change our practices, or should at least start to get us to think to change our practices?
Yeah, I mean, that's always a question, right? Like I talked to you about the studies and those are really going to change anything. And it's interesting thinking about what they were measuring and how that relates to our clinical practice. Is less hypotension enough to change practice? And maybe not by itself, but it's probably an important first step. The study did show improved hemodynamic stability, but it really didn't show those harder endpoints that we like to see, like lower mortality, MIs, length of stay, things like that. But, over the last decade, our literature is really increasingly linked together intraoperative hypotension and MIs and AKI and delirium. And if you can have less hypotension, certainly that's the direction you want to go. What's keeping us from using remimazolam? Also, it's a bit of a newer drug, right? And I think some of the barriers there include the costs. It's probably about $50 for a kind of a standard dose that you might get, where it could be like a buck for propofol. And it's really not available everywhere. And people maybe not as familiar with the drug at all and are very comfortable with propofol. So it isn't enough to really be better than propofol. It's really got to be better enough to justify switching drugs and switching your practice. So I think it gives you a lot to think about. And I think if you have access to the drug, I think it's a good idea.
Well, let's turn to a study that considers the value of anesthesiologists in procedural settings.
Yeah, so this is from the journal Anesthesia in 2025, and it is entitled The Association of Anesthesia-Directed Sedation with Unplanned Discharge Toward Nursing Home Following Non-Ambulatory Interventional Radiology and Endoscopic Procedures. So it's a mouthful, but they're basically trying to show that when we're comparing an anesthesiologist versus non-anesthesiologist directed sedation, what happens with patients? Or do they end up going to nursing facilities? What's their length of stay? Do they go to the ICU? Things like that. GI and IR procedures are some of the most commonly performed worldwide procedures and the most performed in the NORA space as well. And we're giving sedation to these patients, ideally to enhance their comfort, reduce their anxiety, and really to facilitate actually having a quality exam done. And there's an assumption that anesthesiology-directed sedation results in better outcomes. But really, the issues are this limited availability, and these high costs can pose challenges for me in the current demand for anesthesia services, which has been talked about a lot in recent years. And so there's been this kind of necessitated shift to non-anesthesiologist directed sedation to try to reduce costs and improve access to care. So what these authors did, it was a retrospective study that was done at a large academic center from 2016 to 2022. And adult patients who prior to admission lived independently and received either an anesthesiologist directed or a non-anesthesiologist directed sedation for non-ambulatory GI or IR procedures. And the primary outcome was adverse discharge and post-procedural hospital length of stay. They defined adverse discharge as going to a skilled nursing facility or a nursing home of those patients who had previously lived independently. And they also threw in hospital mortality as part of that definition. And then they also looked at things like admission to the ICU after the procedure and different hospital costs. And then an adjusted analysis was also done to try to keep patient selection and bias at bay in this process.
And then overall, the findings were,
So they ended up having a lot of patients in the study. So there's 22,000 plus patients in the analysis, and patients that had a anesthesiologist directed sedation had a lower risk of adverse discharge to a nurse facility compared to those who had a non-anesthesiologist directed sedation. So it was 9.2% with anesthesiologists and 21% with non-anesthesiologists, and that adjusted risk difference was about 4.3%. But even more compelling also was that there was a association with a shorter post-procedural hospital length of stay by 1.4 days and a significantly lower risk of a new ICU admission after the GI procedure. Another interesting finding is that there was actually lower hospital costs involved with the anesthesiologist involvement. The absolute cost savings in that anesthesia cohort was $7,359. And a lot of that was primarily from the shorter hospital stays. And one of the telling parts of the study, which may explain, what was going on, was that the time between vital sign measurements was shorter and with fewer missing values among the patients that had an anesthesiologist involved compared to those who did.
well, that's very interesting findings. So is that the explanation, you think? The vital sign interval or the monitoring interval?
Yeah, I think that plays a large role. I mean, because I don't think the answer is that we're better at giving propofol, even though you can teach people to do that. But I think that's not necessarily just because we use that drug. In the study, the majority of anesthesiologists use propofol, but some of the non-anesthesiologists did as well. And it's really more likely that anesthesiologists are excelling at things like patient selection, recognizing instability, rescuing the airway, giving vasoactive medications. Even our level of communication with the proceduralists might have played a role in what we're doing here. And the value is really in that decision making process rather than the drug administration, I would think. But there are some important limitations to the study, of course, right? It's not like such a slam dunk that, anesthesiologists are always going to be vastly superior in every situation. I mean, there probably was some element of selection bias in that the high risk patients are, more likely to receive care from an anesthesiologist. And they attempted to adjust that, but there's probably always some confounding that always exists. So it's still, despite treating sicker patients, there was better outcomes that were associated. And I think that's pretty compelling.
Well, we talk about these studies, and obviously, it's hard to extrapolate into significant changes in practice from a system standpoint. But if thinking about this one, do you think hospitals should do anything with this study?
I mean, I think anytime that you look at, oh, okay, the length of stay was shorter and it was cheaper, right? I think those are numbers that are hard to ignore. But especially if you really believe in what the study was saying, you believe it was done well. Hospitals want focusing on efficiency, cost, and throughput. And this really suggests that we will improve length of stay and ICU utilization and even downstream costs. And maybe we can have more anesthesia departments be part of the cost saving solution than the cost center that I think a lot of them get a rap for. This doesn't mean that absolutely every patient procedure needs the expertise of an anesthesiologist, but I think there's a case that, like in our last study, these sicker patients, they're having complex ERCPs or even other the advanced endoscopy GI procedures. There's a reason that I think that we bring a lot of value, and I think hospitals should be able to see that.
Well, I do want to ask you about one more study. There's a growing population of patients on buprenorphine presenting for endoscopy and procedural care. What should listeners know about buprenorphine?
Yeah, I thought this was just interesting paper to include in our discussion. It's from RAPM, Regional Anesthesia Pain Medicine, and it's entitled Unrestricted Insurance Coverage of Buprenorphine Formulations Remains Sparse in Comparison to Conventional Opioids. And as some people may use that practice or be aware of buprenorphine, it's a Schedule 3 opioid analgesic, but it has some unique properties that gives it a more favorable safety profile compared with a conventional full like mu opioid in terms of respiratory depression, lower abuse and overdose potential. And it's really been recommended as a alternative first line opioid analgesic. And although bupropion utilization has risen recently due to relaxed prescribing requirements and growing clinical support and also some generic formulations, there really does seem to be kind of a barrier imposed by commercial and Medicare health plans that limit its accessibility. And, the authors, without getting too much of the details, they found that the on-label buprenorphine formulations were covered less frequently than conventional opioids or tramadol, even though there's all these benefits to this drug. And, why we're talking about buprenorphine with this kind of Nora focus is that it really represents a much larger trend in our patient populations. Many of our patients will be on this drug or should have this drug. And today's GI patient increasingly has chronic pain and can develop opioid tolerance and polypharmacy issues and making sedation more difficult. And so it's interesting to look at this interplay and the growth of this drug and what this could mean for the future of the patients that we take care of.
So tie this all together for us. Like, if you take all these things together, what do the studies tell us? How might they inform our clinical practices, especially in the GI realm with anesthesia?
Yeah, these new drugs, and these are showing us that we're going to be seeing a lot of change and already have seen a lot of change in the next decade, I would say for sure. 20 years ago, the practice was mostly screen colonoscopy, right? And today we're doing all these almost endoscopic surgeries, but they're GI procedures like submucosal dissection of tumors and myotomies for achalasia. And they're longer procedures. We have sicker patients and there's greater challenges. And, I think some people feel this way. It's almost as if GI is really becoming its own type of subspecialty in anesthesia. And you could debate here or there whether or not, but there really is some special knowledge that people really should have when they're taking care of these patients. Just the knowledge of when it's appropriate to secure the airway and when it may not be necessary to do so. All the interesting physiology in GI that can occur that can affect your anesthetic plan, and the very fact that you really deal with some of the sickest of the sick patients in the hospital that really aren't surgical candidates, and you're taking care of them, and the procedures are low risk, but the patients are anything but. And it's a very different skill set to approach these patients when you're comparing it to your typical screening colonoscopy. In the next, I don't know, 5 years or so, I think that we're really gonna start emphasizing less the propofol that we're getting and everyone's happy. And we're really gonna have more emphasis on, are we treating this patient's physiology correctly and optimizing their hemodynamics with new things we have available. And I think the future is bright, and I think our contributions are going to be really essential to all these procedures in the future.
Yeah, certainly the and the irony of advancement of medical care as procedures get less invasive, the complexity to take care of them, i.e., anesthesiology care, gets increasingly difficult, it seems like, or it requires a whole new set of considerations and a little more intricacy than what has been in the past, I feel like.
Yes, certainly. Certainly. So many patients, the volume is great, and they're coming from places like the ICU. And you kind of change your mindset a little when you're taking care of these patients in these places that are often far away from the operating room. And, you're really getting into all these other considerations, like how you're going to ask for help and who's near you that can assist you. And a lot of these, proceduralists and the procedural nurses, maybe this might be the first time they're actually working with an anesthesiologist, right? They may not really know what our needs are in the same way that the surgical areas might. And so, yeah, I think the trend is just going to be continuing to have these patients that can really benefit from less invasive procedures, but they're very sick. They're very sick. And I remind everyone in my department that there's a high volume, but at any point, like, you have to be ready to rescue. So exciting for the future.
Certainly. Well, Dr. Primm, thanks again for joining us and taking us through some of these recent findings. And it's always a pleasure to talk about summaries of emerging evidence and always interesting to talk about what we discover. So thank you for joining us.
My pleasure, Adam. Thanks again for having me on.
And for our listeners who are interested in checking out this SEE program, or Summaries of Emerging Evidence, you can check it out on the website at asahq.org/SEE, or C for short. Thanks again for joining us on this episode, and please tune in again next time. Take care.
Hello, ASA. I'm Dr. Patrick Guillaume, your ASA president, and this is the Monday Morning Minute. First, trademark applications filed by the American Association of Nurse Anesthesiology to register marks incorporating the term nurse anesthesiologist have been withdrawn following opposition proceedings brought by ASA before the U.S. Trademark Trial and Appeal Board. The withdrawals represent a decisive victory for ASA and an important milestone in our ongoing efforts to prevent improper and inaccurate use of medical titles and to protect patient access to accurate information about their care teams. Next, ASA Plus is a new personalized education subscription that keeps anesthesiology learning at your fingertips wherever you are. It's app-based, mobile-first learning that fits your schedule, tailored to your interests, role, and career stage. And last, ASA's Committee on Rural Access to Anesthesia Care hosted its second annual Rural Perioperative Symposium. On July 15th, a congressional committee unanimously approved the ASA-led H.R. 9642, the Medicare Access to Rural Anesthesiology Act, to expand patient access to anesthesiologists in rural areas. The bill is teed up for possible consideration by the full U.S. House of Representatives. Well, that's it for now, and I hope you'll follow us on your favorite social media channels and check out my weekly Monday morning outreach.
For more detailed and timely information, don't miss Dr. Guillaume's Monday morning outreach email, delivered exclusively to ASA members' inboxes every Monday at 5 a.m. Eastern. Discover the most important emerging knowledge from around the globe, including key insights and specialty advancements you can apply to your own clinical practice. Through 200 multiple-choice questions and discussions, this engaging program helps you enhance your knowledge whenever you have a moment free. Try a sample question at asahq.org/SEE. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.